Hello everyone. So in the last video we started with diagnosis of pregnancy in first trimester. We reached somewhere over here, the Palmer's sign. So let's continue. Yeah. So Palmer's sign, it is regular and rhythmic uterine contractions elicited during bimanual examination. So whenever you do bimanual examination, you see the regular and rhythmic uterine contractions. So the uterus contracts when you do the bimanual examination. So that is what you need to keep in mind, and it appears 4 to 8 weeks. So in the last part of the last video, I said it as 4 to 6. It is 4 to 8 weeks. Next, coming to the immunological test for diagnosis of pregnancy. So as you all know, SCG is the main thing that is being tested, that is always tested for the diagnosis of pregnancy. So there are different ways of going about testing HCG. So let's discuss each of them one by one. So pregnancy test detects the presence of SCG in maternal urine or serum. The hormone is secreted by trophoblast shortly after implantation and is detectable within days of conception. So trophoblast, which is a part of the placenta, secretes this, and since placenta is present only during the pregnancy, even this thing is present only during the pregnancy. Urine based immunological tests, and then there are serum based immunoassays. So here there are 3 and here there are 3. So first one, agglutination inhibition test, latex test, and there is sensitivity of 0.5 to 1 international units per ml. Time is 2 minutes and absence of agglutination indicates pregnancy and positive 2 days after missed period. So this is the first test. I am not really going into much detail because it is mainly memory based of how you will be studying this. So the only thing what I can do personally is compare each of these sensitivities and the time durations. So comparing is the best way of going about remembering this, not the absolute values. Absolute values, if you try to remember, it will be very, very difficult. Absence of agglutination, so that is the first one. Next one is direct latex agglutination test, where the sensitivity is 0.2 international units per ml. So compared to this thing is less. So what does that mean? So even with much lesser value, this thing can detect HCG. So presence of agglutination indicates pregnancy and positive 2 to 3 days after missed period. So here it is 2 days, here it is 2 to 3 days. Next, last one is ELISA, which is 2-site sandwich immunoassay. Sensitivity 30 to 50 milli international units per ml in the urine and 1 milli international units per ml in the serum. So this is the difference. ELISA is a very complicated and high-end technique, and that is how it detects it. And this one, the special thing about this is it is positive on the first day of the missed period, because even at a very small value, this ELISA detects the HCG that is present in the urine, and also it can detect HCG in the serum, and the time duration is 4 to 5 minutes. Color bands in the test window indicate pregnancy. So that is something. So let's look at it. ELISA pregnancy test. So the real one is directly not available, but there are different color bands that are seen. Maybe this is the one, home pregnancy test, wherein ELISA is used. Next one is serum based. So first one is ELISA itself, which is the thing that was repeated here. Sensitivity is 1 to 2 milli international units. Time is 2 to 4 hours and positive 5 days before the missed period. So this thing is through serum based, and it is positive 5 days before the missed period. Radio immunoassay sensitivity is very low, not very low, the detection rate is very high, and it can detect it very easily even at such a low value. Doesn't mean the sensitivity is low, sensitivity is very high, it can detect it very easily, that is what it means. Time is 3 to 4 hours and detects pregnancy as early as 8 to 9 days post ovulation. And lastly, immunoradiometric assay IRMA sensitivity is 0.05 milli-international units per ml and time is 30 minutes, and positive it is positive 8 days after conception. So we are done with these immunological tests. So first one urine based test, second one serum based test. So urine based we have agglutination inhibition test, direct latex agglutination test, and two site sandwich immunoassay. Then we have serum based, which are ELISA, radioimmunoassay and immunoradiometric assay. So we are done with this. Now coming to finally ultrasound in the first trimester. Ultrasound is a non-invasive, reliable tool for early diagnosis of the pregnancy. Gestational sac. So what are the things that we detect? Gestational sac, fetal viability and gestational age, Doppler effect. So firstly, gestational sac detected via transvaginal ultrasonography as early as 29 to 35 days of gestation. 29 to 35 days of gestation. Appears as a gestational ring by 5th week. So what do you see? Gestational ring USG. So you can see the gestational ring. This is how you diagnose the gestational sac. Fetal viability and gestational age, yolk sac visible by 5.5 weeks. Fetal pole and cardiac activity detected by 6 weeks. Fetal pole, let me check if the mic is on. Yes, it is. Fetal pole and cardiac activity detected by 6 weeks. Embryonic movements observable by 7th week. So poles and cardiac activity, the heart activity and the poles, the two poles that are there, those are detected by 6 weeks. Embryonic movements, so movements by 7 weeks. So 5.5, 6 and 7. Yolk sac, poles, cardiac activity, movements 5.5, 6 and 7. That is fetal viability and gestational age. Lastly, coming to Doppler effect. Fetal heart rate can be reliably detected by 10th week using Doppler ultrasound. So 10th week we can use Doppler ultrasound to detect the fetal heart rate. So let's see Doppler FHR. So you might have seen this instrument or this device in the OPDs a lot. So that is what it does, measuring the fetal heart rate. Importance of early ultrasound differentiates between true gestational sac and pseudo gestational sac, confirms fetal viability and assists in estimating gestational age. So let's see this. Pseudo gestational sac. So it is seen in ectopic pregnancy and it is irregular in shape, centrally located but it is not implanted in endometrium. Double decidual sign, which is something seen in this case, is not seen here. Shape is irregular. Contents, it is totally empty, whereas this contains true gestational sac, contains yolk sac and fetal pole, and blood flow using Doppler, no surrounding blood flow. Here there is blood flow. So that is the importance of ultrasound, and confirms the fetal viability using these three things: yolk sac, fetal pole, cardiac activity by 6 weeks, embryonic movements observable by 7th weeks. So with that we get the gestational age, and with this we conclude the section on the signs and symptoms of early pregnancy. and also diagnosis of early pregnancy, meaning pregnancy in first trimester. So what did we learn overall? The subjective symptoms, which includes amenorrhea, morning sickness, which is very common, frequency of micturition by pressure effects and other things, breast discomfort due to the hormonal effects, fatigue, which is generally seen, and then we learnt about different signs. There are the breast signs, Montgomery tubercles, on per abdomen, how it changes from a pelvic organ into an abdominal organ, pelvic changes. We learned some named signs, Jacquemus or Chadwick signs, and we learnt how blue is repeated so many times. So blue over here on the vaginal wall in this particular case, bluish discoloration of antevaginal wall, same thing. And then we learnt about Osiander's sign, which is increased pulsation on the lateral fornices. Then cervical one, Goodell's sign, softening of cervix. And then we learnt about Piscase's sign, asymmetrical uterine enlargement in case implantation is lateral. Hegar's sign, softening of lower uterine segment. And finally the Palmer's sign, which is regular rhythmic uterine contraction during bimanual examination. Then we learnt about immunological tests, which is urine based, which could be urine based or serum based immunoassays. Overall goal is to detect HCG. And here we have seen agglutination inhibition test, also known as the latex test, and we learnt about different, and also direct latex agglutination, two-site sandwich immunoassay, which is ELISA or the CAR test. We learnt about the sensitivities, how much time it takes, and overall when it detects when it detects whether it's positive or negative. And over here we have seen in serum, we have seen ELISA, radioimmunoassay and immunoradiometric assay. And finally we learnt about the ultrasound in first trimester, how it is used to detect gestational sac, fetal viability and gestational age, and Doppler effect. With this we conclude the diagnosis of pregnancy in first trimester chapter. So the thing is, after finishing this section, diagnosis of pregnancy, I started recording this. What is this? Molding of fetal head, and this particular topic, and I'm presuming, like I know for sure 100%, like a lot of topics down here would have terms like these: vertex presentation, suboccipitopragmatic, all transverse, mento-vertical, and all of it is very, very confusing. So even for someone, like even when I try to study OBG, like every time I go through this, it is very hard to wrap my head around it. So right now, first step would be to understand what all of these means, like all of these, meaning all these words, diameters, what does presentation mean, and all that. So that is the first step before we go on to all of these and the rest of the obstetrics. So what would be the best way of going about it? So in my personal opinion, like since I am doing this, I'll do something like, wait a second, just copy this first and I'll paste it here in a new chat. So the prompt would be, I'm learning obstetrics, and I have a hard time understanding all the diameters, presentations, and words like vertex, transverse, occipito, etc. Occipito, right, occiput anterior and all that. It becomes very much confusing. So this is an example answer. This is an example topic from my exam. So now I paste the topic here everything, and based on this I'll try to get an output of ChatGPT such that it becomes easier for us to go through the next section. It's fine if there are a lot of these things. Overall, the goal is to give it an idea of what we are trying to do, and so that we can best understand what is coming. So this is the topic, and well flexed and all that. So finally we ask, what's the best way to deal with this? There are a lot more topics like this, like these. Like I can do this, meaning trying to imagine this as I read, as I do it, but the thing is it won't be beneficial for the person as a viewer. So this is the best way of going about it. Let's see what the output is right now. So if you are really thorough with all of these, it would be best for you to skip this section and move on to the next topic, or else just go through the notes. But if you really want something in depth, proper simplification like thing, it's better you watch this. So let's see, simplify each concept in your own words. Break down the word like molding, diameters, presentation, simple words. Molding, the baby's skull changes shape to fit into the maternal pelvis. So this one makes sense. Vertex presentation, the top of the baby's head is coming out first. Yeah, this one also makes sense. So vertex generally means top of the baby's head. So top of the baby's, okay, this one is vertex presentation. Yeah, this one makes sense. Draw and label diagrams, so that is what it is saying, suggesting use analogies, think molding like squeezing. Okay, this one is fine. CPD is the cephalopelvic disproportion, is like trying to fit a big object through a smaller hole. Okay, teach it to okay, leave this. So right now we'll try to go through this particular thing. After we have gone through this, what is it, the basic meanings of all these, so we know what vertex means. We want to know what these two means, these two things mean. So these two particular, let's check. So since these are diameters, we need to know what exactly, like it's best if you look at the pictures and all that, but let's see what this thing gives. The distance between suboccipital region, just back of the head near the nape of the neck, to the bregma, soft spot near at the top of the skull. So let's check on the internet what this means, but this is going to take a really long time, really long time, because we are starting from the basics. So suboccipito bregmatic, suboccipito, so from here suboccipito bregma, this is the bregma, suboccipito bregma, it is 9.5 centimeters apparently. Yeah, so even here it is mentioned. Wait, let's go to ChatGPT. Here it is 9.5. yeah, definition. Okay, white matter, the baby skull is well flexed, this diameter enters the, okay, when the head is well flexed, so you can flex your head. I can't show it in my camera, it's very sad. So if you flex your head, the first thing to enter the canal is this one, suboccipito bregmatic diameter, meaning from suboccipital region to the bregma, and they are talking about this is being the compressing part. As the baby's head moves, this diameter gets slightly smaller to help the head fit through the birth canal. So this particular diameter enters the canal, and because of this, canal is small, so this diameter becomes small. So something should increase in this thing, right? So if this becomes small, this can't just burst open, you can't make a hole out of this. Blood can't come out, blood stays in, brain matter stays in. So overall what happens? This elongates, so that itself is molding. So mento-vertical diameter, the elongating part. So mento-vertical, let's see, verticomental, same thing. So if this thing shortens, which is suboccipito bregmatic, these two If this thing gets shortened, something should increase, this thing increases, so that is molding. So now we have understood it very much clearly. So this thing is not required. Now coming to this one. Yeah, so now this becomes much more easier to understand. So even for me, I didn't expect this. Yeah, it's fine. Yeah, so molding refers to the alteration in shape of the fetal head as it passes through the resistant birth canal during labor. This process allows the head to adapt to the dimensions of the maternal pelvis, facilitating vaginal delivery. So it passes through the birth canal, right? So shape of the fetal head needs to adapt to the maternal birth canal. So the process of alteration of the shape, when this thing happens, when this thing, what is that, passing through happens, that itself is molding. Despite these changes, there is minimal alteration in the overall size of the head due to incompressibility of intracranial content. So as I mentioned, right, so you can't just have a hole in the head from where blood comes out, leaks out, or brain matter leaks out. Everything is inside. So everything is inside. So because of that, the shape needs to change. So that shape change is equal to molding. So mechanism. So this is what we learned on ChatGPT. Molding involves compression on the engaging diameter of the head, accompanied by elongation at right angle to the compressed diameter. So right angle compressed of the compressed is verticomental, and the engaging is this one, suboccipito-bregmatic, suboccipito to the bregma. Next one, yeah, elongation of, so what is it? So this thing is engaging, suboccipito-bregmatic in the vertex presentation, which is in case of well flexed head, well flexed. So if you flex nicely, that is what happens. Montovertical diameter, which is usually 14 centimeter, that is the one that increases in length. Overall, the overlap of skull bone. During molding, the parietal bones overlap the frontal and occipital bones. In the first vertex position, the right parietal bone tends to override the left. In first vertex position, the right parietal bone tends to override the left, reversing in the second vertex position. So we need to know what these things mean also. I'm really sorry if you are expecting something like me explaining everything, each of it one by one. I'm not an expert. Yeah, I'm trying to learn, and in the process you are also learning something. Yeah, overlap of the skull during the molding. So okay, this we know. There are multiple bones from anatomy we know, frontal, parietal, occipital, which are fused at birth. During the labor, the head squeezes through the birth canal. Parietal bones of the parietal bone side of the skull slide over the frontal and occipital bones. So some bones slide over the other. So which are those? Parietal slide over the frontal we know on the front, and occipital back. Okay, so they slide parietal, which are on the side, parietal bones, they slide over the frontal bones, the bones on the front and the bones on the back. Overlapping reduces the head size. Okay. So the overlapping of bones. So the suture thing, you leave the suture part. So and there is the overlapping. So first and second vertex position, what's happening? Yes, exactly. What does it mean? The baby's head does not always enter the birth canal in perfect centered position. It usually turns slightly. Yes, this we know. It's not perfect. The vertex position refers to the way the baby's head is rotated in the pelvis. Okay, so in the pelvis, so let's see pelvis, female. Okay, in this particular pelvis, the baby's head is not perfectly aligned, meaning not 100% vertical. So there is some kind of rotation here. So that's what they are talking about. First vertex position. The baby's occiput, the back of that, is towards the left side of the mother's pelvis, to the left occiput. So this is LOA, left occipito anterior. So this seems to be the most commonly held position by the fetal skull. Baby's occiput, which is the back of the head, towards the left of the fetal, towards left of the maternal pelvis. So maternal pelvis is where? Here. So this is right side, this is left side. So this left side, so left occipito anterior. So what is it? Baby's occiput back is towards the left side of maternal pelvis. So okay, this side is what the occiput of the baby is. So that's what it means, left side of the maternal pelvis. Second vertex position, which is right occipito anterior. The baby's occiput is now towards the right side of the maternal pelvis. So this is the opposite. Here the left parietal bone overrides the right. So in this particular condition, apparently when in the second vertex position, the overriding of parietal bones take place. Why is this important? This natural overlapping helps the head mold to the birth canal, making passage easier. If molding is too extreme, it is obstructed labor or cephalopelvic disproportion. But one thing, why specifically in this case? Why specifically here there is overriding of parietal? Like for the sake of exams, yeah, we can just memorize this and go, but better to know why in that particular condition what's happening. So let's change this one, GPT auto. Okay, let's try out a new one. Copy this. In ROA position, the fetal occiput is oriented to the right side of the with the fetal head typically engaging on the left oblique diameter of the maternal pelvis. The overriding of left parietal bone over the right occurs due to mechanical forces of the labor and normal molding of the fetal skull. Pressure and distribution. So sure, we are going into more extreme. No need of this. So yeah, coming back, in this vertex position, the right parietal bone overrides the left. So the first vertex position, the right parietal bone overrides the left, reversing in the second vertex. Oh, okay. So overall, we don't have to know all that. So the thing is, in the first vertex position, one of the bones, so the right parietal bone. So, but there are two parietal bones, the right parietal and the left parietal. The right parietal overlies is on top of the left one. But in the other case, where in the second vertex position, the other bone, the other side overlies the first side. That was simple actually. Unnecessary wasting of time. Degrees. So degrees of molding, 3 grades, grade 1, 2, 3. Bones are touching but not overlapping. Okay, makes sense. This is considered normal, facilitating easy passage through the birth canal. Grade 2, bones are overlapping but easily separated. So bones are overlapping but easily separated. Indicates moderate resistance during labor but usually manageable. So they are overlapping but can be easily. Okay, makes sense. Bones are fixed, that is third grade. This is a sign of extreme molding, may indicate cephalopelvic disproportion associated with risk such as intracranial hemorrhage and tearing of tentorium cerebelli. So first we need to, let's see what cephalopelvic. It's a separate question by the way, but in this particular case, let's just ask CPD, what is it? Occurs when baby's head is too large to pass the maternal pelvis, making the vaginal delivery difficult or impossible. This mismatch is due to various factors. So either the fetal size is big or the maternal size is small. What maternal size? Maternal pelvic size is small. So that is what it is. So the third grade, which is the extreme grade of the bones being very fixed and cannot being and the inability to be separated, and when we can't separate those, that is an indication of cephalopelvic disproportion. So that is what it means. We just checked what it is. Associated with risks such as intracranial hemorrhage and tearing of tentorium cerebelli. So tentorium cerebelli is one of the let's see, I don't know what it's what's the description of that, but I remember the image. Tentorium cerebelli. So that is this, but separating this one, what is it, separating the cerebrum from cerebellum, that thing, this thing, that is, that rupture of that can happen because it is like very stiff and all that. Importance of molding. So facilitates passage through the birth canal, indicator of labor progression, pathological implication, assessment of fetal positions. First one, molding is inevitable and beneficial in most vaginal deliveries. This one made sense. Yes, it enables the fetal head to adapt to the maternal pelvis, allowing smooth passage through the birth canal. Yes, this also makes sense because that is the main importance of that. Indicator of labor progress. The degree of molding can provide important information about labor progression and fetal head. Oh, this thing has not started yet. Oh my god. It's fine. We'll go till 50 minutes. Yeah. The degree of fetal molding. Not actually 50. I don't actually remember. Actually, I paused the other video. I started teaching. Then I was like, oh my god, this is too hard to explain. I was thinking of a way of going about teaching this. Then okay, then I was like, let me continue with the same thing, whatever approach I'm doing, like ChatGPT, this and that, but it will take more time. Though it is a small topic, it will take more time, but overall, by the time we reach the end, the time taken would be less because we are understanding each and every concept as we go. So coming to the second point, sorry about that. Indicator of labor progress. The degree of molding can provide important information about labor progression and fetal head engagement. So as it passes through the molding and all, the molding X at a particular station is different from molding Y, which is at a different station. That is how I understand it. Slight molding is common and expected in normal labor. So molding X, it doesn't actually make mold X. Mold X is different from mold Y. Both, and mold X, mold Y at different stations. Pathological implication. So station is different levels. So if you can't recall, different levels. So one is at the ischial spine, the ischial tuberosity, is that the thing? One is much lower down and all that. So there are different levels of the pelvis. Like as the labor progresses, the baby comes down. This thing becomes from negative, it becomes positive. What is it? The stations turn from negative to positive, and there is 0 in the middle. So extreme molding may indicate obstructed labor. We have already seen that, and disproportion between the fetal head and maternal pelvis can lead to severe complications such as we have already seen this, subdural bleeding also. Assessment of fetal position. The shape of the molded head can provide clues about the position of the head in the pelvis. So as I mentioned, right, mold X being different from mold Y, and X and Y being different sides of the pelvis, meaning different station sites, like overall you can say both are somewhat similar. Finally, coming to related condition, which we are going to learn here. Yes, so caput succedaneum, yes, that's how we pronounce it, refers to the swelling of the fetal scalp due to fluid accumulation above periosteum. So there is periosteum, so bone above that, the covering is periosteum. So above periosteum, caused by the pressure from dilating cervix or vulval ring. Caused by pressure from dilating cervix. So the cervix, it dilates, and the pressure as it dilates on the fetal head causes this thing. So it's here. Wait. The swelling is diffuse and boggy and crosses the suture lines. So it is not limited to periosteum, right? It's not under periosteum, and it's not. So if it was under periosteum, it would have been something like it wouldn't pass the suture lines, but this is over it, so it will cross. Typical results within, I will go over it, what it means. Typical results within 24 hours after birth. So by 24 hours. So we have seen overall what this thing is. This took a really long time. How many minutes? Almost 20 minutes. It's fine. It's fine though, because we have understood like suboccipitopragmatic diameter, what it is, mento-vertical diameter, what it is, what is the relation of these two, we have learned that. And then we have learnt about the overlapping of bones on one particular side. If there is one type, on the other side, that is just opposite of that. So there is reversing that is happening in the second vertex position. And we have seen the degrees, grade 1, 2, 3, and we have seen the importance, how important it is. And finally we touched upon the caput succedaneum. Yeah, so that comes to the end of, that ends this section. Now coming to the caput. So caput is the second one. So caput succedaneum and differentiation from cephalohematoma. Caput succedaneum is a common finding during or after delivery, characterized by swelling in the newborn scalp. So okay, it made sense, right? So there is swelling just above periosteum. So you can see there is this. Let's see an image, that would be better. Caput succedaneum. Yeah, this one. Yeah, so this is periosteum, Gilia panoretica. So that is just above that. So just above that there is this swelling. Yeah. Where were we? The formation due to stagnation is a common during delivery, after delivery. Yes, understanding its mechanism is very important. Yes. Caput succedaneum definition. It is the formation of swelling due to stagnation of fluid in the layers of the scalp beneath the girdle of contact. So what exactly each of, so this exact, that is the issue I have with that. It's like, unless you copy paste this thing into ChatGPT, you can't understand what it's trying to say. Meaning, is a fluid stagnation. Okay, fluid builds up under the skin of the scalp, layers of scalp. The fluid collects in the soft tissue just under the skin. Okay, beneath the girdle. Yeah, the swelling forms where the head was compressed. Okay, the swelling forms where the head was compressed. This made sense. Girdle of contact, the area of pressure. Okay, fine, this makes sense. Bony. Okay, mother's pelvis. Okay, fine, makes sense. Cervix, as the head pushes through the birth canal. Okay, makes sense. Vulval ring, the opening of vagina during delivery. Yeah, see how it could have been written more in a more simpler fashion, but no, it is supposed to be hard. Okay, fine. Mechanism of formation. As the fetal head descends and presses against the dilating cervix, so as we go through this, you might realize how strong my OBG is. Like particularly, I don't have an impressive amount of knowledge or understanding of this particular subject, but we shall make it through. By the end of this particular section, entire subject, we would be well thorough with a lot of important topics. Yeah, mechanism. Mechanism of formation. As the fetal head descends and presses against the dilating cervix or vulval ring. Okay, this one made sense, right? The scalp areas in contact with the girdle of contact are compressed. Yes, this now it makes sense completely. This compression interferes with venous return. Yes, makes sense. And lymphatic drainage leading to stagnation of fluid and swelling. Yes, makes sense. So caput typically develops after the rupture of membranes and manifests as a diffuse boggy swelling that crosses the suture lines. So after the rupture of membranes and manifests as diffuse. So the thing is, it needs to happen when it is beneath the girdle of contact, right? So that only happens when after the membranes are rupture. So what this is present as the diffuse boggy swelling that crosses suture lines. So we have seen it already. So here there was a suture, see, but it is crossing the suture. So that what it means. This one you forgot about this. This one is from the textbook. If you want, you can see this. I'll probably cut it off. not supposed to be. Next, coming to clinical features, location, consistency, extent, timing. So about the spelling is not spelling, swelling per se. So as I teach, right, as I speak, I might misread certain words. So the thing is, the things over here are correct. What might come out of my mouth, like misreading and all that, those are misreading, not purposeful, because it takes, I am not an expert at reading for really long periods of time, reading meaning with my words, mouth being open. So because of that, issues come up, and this is one of an issue. And then another issue is, I am thirsty right now and I don't have my bottle near me, but it's fine. Wait a second, I drink some water. I think I have the bottle here. Yeah, I have the bottle. Yeah, extent, diffuse swelling that is not limited by suture. Okay, this makes sense. Timing, present at birth and develop shortly thereafter, typically resolves within 24 hours. So resolves within 24 hours. This is quick. Yeah, maybe because it is important, maybe because it looks really scary. Like imagine you look at this, and if you don't have knowledge about this, how would you feel? Probably that has increased its importance, or we are yet to see what the importance is. Yeah, present at birth or develop shortly thereafter, results in 24 minutes. Yeah, so we've seen this, and soft, boggy, compressible. So that is the consistency. Yeah, it shifts depending upon the fetal position. Yeah, coming to importance, indicator of static position, suggests the head has remained in the fixed position for an extended period. So the girdle of contact, it is pressing and pressing, and so when you have so much of pressure for a long period of time, you develop that. So assessment of fetal position, in left position, caput forms over the right parietal bone. In the right position, it is in the left parietal bone. With increasing flexion, the caput is more in the posterior. So as you can imagine, occipito-posterior, occiput being in the posterior section, and like it is hard to imagine actually, but these are the key this thing, what are the key rules, key principles. If it is left side, it is developed on the right. If it is on the left side, if it's on the right side, it's developed on the left. But with increasing flexion, it becomes more posterior. So this is, here there is another term, cephalhematoma. This is a separate question, so integrated over here. So definition, here it is caput succedaneum. The word is slightly Latin. Is it Latin? Not sure, but it's very difficult. The way it is, not difficult, it's weird. The name is weird. Subcutaneous fluid accumulation due to pressure. Subperiosteal, beneath periosteum, blood collection due to vessel rupture. Location, over the presenting part, crosses the sutures. So since this is, we'll see an image, cephalhematoma, here it, cephalhematoma. Yeah, here you had it here, I think it is. Yeah, cephalhematoma, it's here, see, it doesn't cross the suture lines, it's under the periosteum, so white line over the red color. And yeah, consistency, soft, boggy, compressible, firm, tense, and non-compressible initially. So just the difference. Onset, present at birth and shortly thereafter, appears hours to days post birth. So this is maybe more dangerous than this. Yes, it is. Here you can see. Resolution, resolves within 24 hours, resolves over 2 to 3 weeks, 2 weeks to 3 months, really long time. Skin discoloration, here it is not the case. Here possible bruising over the swelling. Here complications none. Here jaundice, because the blood, it is hematoma, so blood that is accumulated will be eventually lysed, leading to like whatever lysis, this goes through the heme breakdown cycle and more of jaundice. Infection, whatever there is in that particular case, in that the collection might get infected, possibly there could be calcification, the accumulation, the whatever is accumulated can get calcified. Treatment, no intervention. Here monitoring. So with this we are done with caput, and the 9th section. Next, coming to antenatal care. So, this is a PSM community medicine topic. Should we go through? Yes, we should, because this is an important topic, that is why we have mentioned it here. So, objectives of antenatal care. Antenatal care, also known as prenatal care, involves systematic supervision of women during pregnancy to ensure the health and well-being of both the mother and the fetus. The main objectives include these: screening, early detection and treatment, ensuring continued risk assessment, promoting health education, counseling on family planning and birth preparation, and ensuring normal pregnancy and safe delivery. So, all of them one by one. First one, screening of high risk cases, identifying pregnancies at risk for complications such as preeclampsia, GDM, fetal growth restriction. Then early detection and treatment of complications, timely management of maternal or fetal issues to prevent adverse outcomes. Timely management of maternal or fetal issues to prevent adverse outcomes. Next, coming to ensuring continued risk assessment, regular monitoring to detect any emerging risk. Promoting health education. So, this is prevention entirely, educating expectant mothers about pregnancy, labor, postpartum care. Finally, counseling on family planning and birth preparation. So, after this thing, after the delivery and all that, the mother should know about family planning and birth preparation. No, not after, before that, but family plan meaning birth preparation, meaning at the time of delivery they need to know about everything, so that after delivery this thing could be taken care of. Yes, delivery option, newborn care and family planning. Ensuring normal pregnancy and safe delivery. The ultimate aim is to achieve a healthy mother and baby with minimal complications. So, first is screening for these diseases, early detection and treatment. So, detection and treatment of various diseases, ensuring continued risk assessment. Next is health education. Next one is counseling. Next one is normal pregnancy and safe delivery. Coming to components of antenatal care, the OPD, we have seen all these things. First one is history taking, detailed medical, obstetrics, surgical and family history, recording gravida, parity, past pregnancy outcomes. So, yeah, next one, menstrual history to calculate the EDD, and yeah, that one Nagil is former, right? Is it here? It's not. Nagil's formula, I will include, it is important. Actually, these are just most repeated ones for OBG especially. These are just the most repeated ones, but there are quite a few more which could be potentially asked. Just saying. But with these you can pass. Like, I am sure I will pass with these if I go through this. Yeah, physical examination. So, physical and general physical, weight, pallor, edema, blood pressure, abdominal examination, fundal height, fetal position, heart sounds, pelvic examination. Routine investigations, blood tests, hemoglobin, blood group, VDRL, HIV, hemoglobinopathies, urine tests, protein, sugar, infection screening. Next one is ultrasound. It's recording, right? Yeah, protein, sugar, infection screen, that is urine. Ultrasound, early dating scan, anomaly scan, growth scans. Early dating, anomaly, growth. Special, genetic screening, serological tests for infections, and glucose tolerance tests for gestational diabetes. So, special investigation. Antenatal advice and counseling, nutritional guidance, exercise recommendation and warning signs, discussions of labor plans, breastfeeding and postpartum care. So this repeats from there, everything repeats from here. but when you look at the OPD wise counseling and all, here it is guidance, nutrition, exercise, warning signs, discussion of labor plans, breastfeeding, postpartum care, regular follow-up visits, scheduled visits at 4th week up to 28th weeks, bi-weekly until 36 weeks and weekly until delivery. So this is generally followed. 4-week intervals up to 28, bi-weekly 36 weeks and weekly, bi-weekly meaning for every 14 days and weekly thereafter until delivery. Importance: antenatal care is pivotal in ensuring well-being of both mother and child. Its significance includes reduction in maternal and perinatal mortality and morbidity, early detection and management of complications, significantly decreased mortality rates. Next one, improved pregnancy outcomes. So mortality, morbidity reduces and fetal growth and development is also regularly checked and while maintaining maternal health. So similar point. Next one, health promotion and disease prevention, immunization, nutritional support, health education to reduce of complication. Psychological support, counseling helps reduce anxiety and prepares women for childbirth and parenting. Early identification of high risk factors enables timely interventions to prevent adverse outcomes. So early identification, we have seen one of the objectives, same thing repeated here, and even this one, like exactly, health promotion, disease prevention. High risk, yeah. Next, coming to preparation of delivery and postpartum care, educates the mother on labor, delivery options, postpartum care, ensuring smoother transition. Was this the point earlier? Yeah, family planning, birth prevention, delivery option, newborn care. Yeah, even this has been given here. Promotes family involvement, encourages partner and family participation in pregnancy care, enhancing support systems. So with that we end this thing on this. So we have learnt about the objectives, screening, early detection and treatment, continued risk assessment, promoting health education, counseling on family planning and birth preparation, ensuring natural pregnancy and safe delivery. Components: there is history taking, physical exam, routine investigations, special investigations, antenatal advice and counseling, regular follow-up visits, and then we have learned the importance, which is just what is given here, but it is the outcome. Next, coming to nutritional and caloric requirements in pregnancy. These are a lot of numbers, so we need to be ready for this. So it is 40 minutes. So let's see. I think with this I will finish off the video. Yeah, I will finish it off, and yeah, I will talk about it later. So proper nutrition during pregnancy is essential for health of both the mother and the developing fetus. The increased nutritional demands are due to growth of fetus, placenta, maternal tissues and increased BMR. So fetus, placenta, maternal tissues and increased BMR. Adequate intake of calories, proteins, vitamins and minerals ensure optimal fetal growth and reduces pregnancy related complications. So just overall summary of what this thing is. Like, we know why it is required, right? There is fetus, there is placenta, there is maternal side, and all the compensatory basal metabolic rate increase, and everything requires more calories, more proteins, vitamins and minerals. Next, coming to calorie requirements, protein requirements, mineral requirements, vitamin requirements, fluid requirements, dietary and overall dietary guidelines, and finally what are the weight gain recommendations, what are the actual BMI numbers. So first, calories. So calories, this is the energy requirement, total calorie intake, and how the calories should be distributed, how they should be distributed. The calorie requirement increases by 300 kilocalorie per day during the second half of the pregnancy compared to the non-pregnant state. The total recommended calorie intake is approximately 2500 in the second half of pregnancy. So, here when I add 300 to the normal state, it becomes 2500 kilocalories. And overall, what should be the division? First one, carbs 55 to 65%, proteins 15 to 20%, fats 20 to 30%. Focusing on healthy fats such as omega 3 fatty acids. So, 55 to 65, 15 to 20, 20 to 30. Next, coming to protein requirements, increased protein needs, and then there are sources of proteins. So, what are the protein needs? Protein is crucial for fetal growth, placental development, maternal tissue expansion. The recommended daily protein increases from 50 grams in non-pregnant women to 60 grams in during pregnancy, 50 to 60. Sources of proteins: meat, fish, poultry, dairy products. Yes. Plant based: legumes, beans, lentils, nuts and soy products. So, I never knew about this. Beans have so much of proteins, and it is almost comparable to meat, chicken, especially the kidney beans. They have almost similar protein content, like in terms of concentration, like per gram. I recently got to know about it. Yeah, coming to mineral requirements, there's iron, calcium, zinc, iodine, folic acid, vitamin D. Iron requirement increases to 40 mg per day to support increase in maternal blood volume and fetal iron stores. What are the sources? Red meat, eggs, green leafy vegetables and fortified cereals. Red meat, eggs, green leafy vegetables, fortified cereals. So, 40 milligrams per day. Calcium requirement doubles to 1000 milligram per day. 1000. Can you imagine? 1000. That is calcium to support the fetal bone development. Sources: dietary products, fortified plant based milk, green leafy vegetables. Yeah, dairy products, everybody would remember, fortified plant based. So, fortification can even enhance the plant based milk, and there are green leafy vegetables. Zinc, so we have seen in this in PET section, needed for cell growth, immune function, recommended 12 milligram per day. 12, first one was 40, second one was 1000, this one is 12. See the variability, 40, 1000, 12. Looks like something like micronutrients and all that. Anyways, sources: meat, seafood, nuts. Meat, seafood, nuts. Coming to iodine. Iodine very important for fetal brain development. What's the value? 175 microgram per day. 175 microgram. So, micro, milli. Iodine is micro. 10 raised to minus 6, right? Yeah, 10 raised to minus 3. Crazy. Sources: iodized salt, seafood, dairy. Iodized salt, seafood, dairy. Folic acid 400 microgram per day. 400 microgram. Recommended to prevent neural tube defects like spina bifida. Sources: leafy green leafy vegetables, fortified cereals, citrus fruits. So, green leaf vegetables, fortified cereals, citrus fruits. Vitamin D requirement increases to 400 international units for bone health. Sources include sunlight exposure, fortified dairy, fatty fish. Next, coming to vitamins: vitamin A, C, B12. A is needed for cell differentiation, fetal growth, and recommended intake is 6000 international units. Sources include carrots, sweet potatoes, leafy greens. Vitamin C, ascorbic acid requirement increases to 70 milligram per day. 70, to enhance the iron absorption and support the tissue repair. Sources include citrus fruits, tomatoes, bell peppers. Vitamin C 70. Vitamin C 70. Yeah. milligrams per day. This one is 6000 international units, previous one was 400 international units. Here it is citrus fruits, tomatoes, bell peppers. Vitamin B12 2.2 microgram per day. Can you compare 2.2 microgram? Doesn't even stand with this. Iodine 2.2 microgram for red cell production, neurological development, and the sources include animal products like meat, fish and dairy. Next, coming to fluid requirements. Increased fluid intake is required. This is obvious. Pregnant women should aim for 2.5 to 3 liters to support increased blood volume and amniotic fluid production. Yes, water, fresh fruit juices, milk and herbal teas. Coming to dietary advice and guidelines. Balanced diet, frequent small meals, avoid empty calories and supplements. So this is I think in general most of the people should be following this to have a healthy lifestyle. But in this particular case, in case of balanced diet, include a variety of foods from all different groups, from different food groups to ensure adequate nutrient intake. Frequent small meals helps manage nausea and maintain steady blood sugar levels. Avoid empty calories. Limit the intake of sugary snacks and beverages that offer little nutritive value, like ice cream, Coke, Coca-Cola and all that. Shouldn't drink all that, but it's fine. Sometimes you can. Not as a pregnant female. Supplements. Iron, folic acid supplements are commonly recommended to meet increased demands, iron and folic acids. So this one we know, right? IFA tablets being taken. Weight gain requirements, there is normal BMI 18.5 to 24.9. Recommended weight gain is 11 to 16 kilograms. In case of overweight 25 to 29.9, recommended weight gain is 7 to 11 kilograms. And in case of obese, which is greater than 30, recommended weight gain is 5 to 9 kilograms. So we have seen all these things. So nutritional caloric requirements during pregnancy. So we have seen the caloric requirements, total calorie intake, distribution of calories, protein requirements, how much protein needs, sources of proteins, and mineral requirements, iron, calcium, zinc, iodine, folic acid, vitamin D, and then vitamins. We have A, C, B12, and we have seen how different the dosages, the recommended values are. So it starts from 2.2 microgram and some things are like 600 international units in case of vitamin A, and then this calcium is 1000 milligrams per day. Yeah, and then calories 2500. So big numbers, and in some places small numbers. And then dietary advice and guidelines: balanced diet, frequent small meals, avoid empty calories and supplements. And then we have weight gain recommendation: normal BMI 11 to 16, overweight 7 to 11, obese 5 to 9. So as you can see, with increasing BMI, the expected weight gain or the recommended weight gain keeps decreasing. Here it is 11 to 16, here it is 7 to 11, here it is 5 to 9. So this is a small principle. Overall, with this we come to the end of discussion on nutritional and caloric requirements. Yeah, so I'll be stopping the recording right now, and I'll be so this is the thing, encoding overload, sometimes it comes up, I get scared. So with this I conclude this today's today's topics. So it is just 1 hour. Even yesterday it was 1 hour. I didn't expect, I expected it to be much more, but then due to some reason I was like, OBG can't do this for 4 hours, because it is maybe it could be done actually, but the thing is it requires certain mind frame. So the thing is, after doing pediatrics, the mind frame is like I shouldn't be doing 3 hours of study sessions. So 1 hour is the best, but even now I feel better to do it topic wise. So topic wise meaning in next video probably going through only this particular section, this particular thing. So it would be easier on my side too, because I can just hit the record button, record it and upload it. and even the video would be much clean. I could add some intro if possible, but in long videos like these, what happens is even if I want to edit it, the time it takes for the export is really long. So in the case of 1 hour, it took around how many minutes? 10 to 15 minutes. Like meaning it is just for basic edits. But when it comes to about 4 hours and all that, like as the number of hours of the video increases, the export time also increases drastically. So because of that, I'm thinking of doing short sections, short videos, topic wise videos, so that it's much easier to edit. If I said some nonsense or something, I can edit it out. So that is what I'm thinking, and also maybe adding an intro to this channel, something which is related to the logo. That would be nice. I'll see what I can do. But overall, we are done with today's topic, meaning this section. So when looking at it from here, it looks like 10 topics are done, but it's not actually a lot. The next ones are much bigger. So these are like so huge, all of these. See, this one is a huge section, this one is huge, this one is comparatively fine, this one is huge actually, and then all of these small topics. Here there is I need to add another section, right occiput anterior, which has been asked. With that, I think I'll end the today's session. I keep mixing session. It's fine. Anyways, in case you like this video, you can like it. In case you would like to watch more of such videos, you can subscribe the channel. And in case you have any suggestions, you can just write it in the comments, or you can write it in the Instagram DMs. I'm ready to, meaning I'll try my best to address the suggestions and implement them in case they are good suggestions. So that's it. Bye bye.